Good afternoon, everyone. Welcome to the ASPPH hosted webinar on the latest supplemental issue of Public Health Reports, the official journal of the Office of the U.S. Surgeon General and the U.S. Public Health Service. On behalf of U.S. Surgeon General Vivek Murthy, I want to thank you for joining us today. My name is Hazel Dean, and I am the Director of the Division of Partnership Support in the National Center for State, Tribal, Local, and Territorial Public Health Infrastructure and Workforce at the Centers for Disease Control and Prevention. I'm also former Editor-in-Chief of Public Health Reports, ending my tenure in March of this year. Published since 1878, Public Health Reports is dedicated to publishing original research, reviews, and commentaries in the areas of public health practice and methodology, public health law, and teaching at schools and programs of public health. Before we begin, a few items of note. This session is being recorded and will be available on the ASPPH YouTube channel shortly after the conclusion of today's webinar. Please note that attendees may receive continuing education credits for Certified in Public Health. You can ask questions or submit comments in writing at any time during the presentations by clicking on the Q&A button at the bottom of your screen. We will hold questions until the prepared content has been presented. Public Health Report's most recent supplemental issue focuses on practice-based health equity from the Frontlines. Today, we will hear from and engage with selected authors from the special issue as they share more insights on their efforts to ensure diverse communities fair and just opportunities to be as healthy as possible amid the COVID-19 pandemic. It is now my honor to introduce the lead guest editor and moderator for today's webinar, Dr. Jeffrey Hall.
Thank you so much, Dr. Dean. Colleagues, it is so exciting to be here with you all today. My fellow guest editors, Drs. Gulzar Shah and Janice Bowie, and we're all very happy to share this Public Health Reports supplement organized by the CDC's Office of Health Equity in today's webinar. Specifically, today, we'll hear from a select group of authors out of all of the amazing groups whose work appears in our Public Health Report supplement. Their presentations will occur sequentially, with each group specifically introducing themselves, and we're going to be doing that specifically so that we make the most of the limited time that we have together today. So having said that, please join me in welcoming our first authors, Ashley Meehan and Christy Clark.
Hi, everyone. My name is Ashley Meehan, and I am the lead scientist for homelessness and health in CDC's Office of Readiness and Response. Today, we're excited to briefly talk about improving surveillance data for people with disabilities, substance use disorder, and those experiencing homelessness. During the COVID-19 pandemic, Next slide. During the COVID-19 pandemic, the team that Christy and I were on saw substantial gaps in surveillance data for people with disabilities, substance use disorder, or experiencing homelessness. We observed pretty great variation in what state health departments were collecting and reporting to CDC. We sought to identify current practices, challenges, and opportunities for improving surveillance data on these groups of people. We did this by conducting 61 in-depth interviews virtually on Zoom. Our participants included 19 CDC staff, 39 staff from 9 purposefully selected state and local health departments, and 3 healthcare providers with informatics expertise. From these interviews, we identified 4 key themes worth highlighting: resource limitations, articulation of purpose, data definitions and policies, and data systems. We felt it important to highlight the voices of the people doing this work daily. So as we briefly share about each theme, we offer an illustrative quote from one of our participants. First, we identified human and financial resource limitations to collecting and reporting data on disability, substance use disorder, and homelessness in COVID-19 surveillance data. Staff within public health and healthcare agencies were stretched far too thin during the pandemic, and asking folks to collect more data or more pieces of information may have, as one participant from a health department put it, been the straw that breaks the camel's back. While staff hired using term-limited COVID-19 funds helped many health departments respond to the surge of activity, this actually hindered long-term and sustainable data system improvement and data collection continuity as funding ran out and staff turnover increased. Next, participants noted that they had limited information about how data on disabilities, substance use disorder, and homelessness would be used to improve health outcomes at individual and population levels. One clinician noted uncertainty around the downstream ramifications of documenting these things in a health record. That may have led some to not put anything down in a chart at all. As the pandemic continued, not having a clear articulation of the purpose of these data also limited case investigators' ability to convince members of the public that this information was worth sharing with official agencies. If there had been a communicated value of these data, members of the public might have been more understanding and willing to provide this information, which might have lightened the load on case investigators. Now I'll pass it off to my colleague, Christy.
Thank you, Ashley. I'm Christy Clark, captain in the Public Health Service and senior advisor on health equity within the Office of Public Health Data Surveillance and Technology. So one principal challenge we uncovered was the lack of consistent data definitions and policies regarding key variables related to these populations. So for example, someone who is providing the exact same information about their housing situation could be classified as housed in one jurisdiction and as experiencing homelessness elsewhere. So that substantially decreases the ultimate utility of these data and creates a situation where data cannot be meaningfully aggregated or compared. As this clinician reported, sometimes that uncertainty creates situations where people will pick unknown or just skip the question altogether. And that in turn can create this vicious cycle where incomplete data are harder to use. When people don't see action taken on the data, as Ashley shared, the data can be perceived as being less useful, and then the fields are more likely to again be left blank. Next slide, please. Data systems, sorry, next slide, please. Thank you. Data systems also presented a problem. So we last talked about data standardization, but many systems even lacked a field to enter important information about these populations. So for what data were collected, the lack of system interoperability presented a challenge to sharing those data. Insufficient data infrastructure, such as legacy data systems that are incompatible with modern interfaces, reflect really a longstanding underinvestment. And as this jurisdiction staff member points out, siloed CDC data systems can be part of this problem. And so the creation even of the Office of Public Health Data Surveillance and Technology is part of this ongoing effort to streamline data pathways, as well as respect jurisdictional workflows. Next slide. So the main takeaway here is that the existing data systems were not designed well to create comprehensive and consistent data for some critical populations, including, but not limited to, the populations of focus for the study. And that limits the ability of public health to take evidence-based actions to support critical populations during public health emergencies. So one really important point is in all of the in-depth interviews, it was clear the people we talked to, healthcare, public health at every level, care deeply about supporting populations on an individual level, on a population level, but we're constrained by many existing systems as well as other logistical constraints, from doing so in the way that they would have wanted to. So the primary and most pervasive issues, I want to reiterate, are systemic, and we are making progress on those through things like data standards and through things like streamlining those data systems and infrastructure grants. But there was other action taken on these findings. While most problems were systemic, there were a couple of very specific knowledge gaps that were identified, particularly with new or surge staff comfort with asking about subjects they perceived to be sensitive during interviews, as well as articulating that purpose behind the data collection. And so the action was we recently released in collaboration with CSTE a course that we had developed to address those two specific data gaps. That is freely available to anyone on CSTE Learn platform or the CDC Train platform. Next slide. That's it for us. We look forward to your questions, and please do feel free to reach out to us individually with questions.
Hello, my name is Kirsten Wyson. I use she, her pronouns. I'm a policy analyst at Public Health Seattle, King County. It's been my great pleasure since September 2020 to staff the Pandemic and Racism Community Advisory Group, which we call PARCAG, along with my colleague Janelle Hicks.
Hello, I'm Wendy Barrington, and I use she, her pronouns as well. I'm associate professor with the Schools of Nursing and Public Health at the University of Washington Seattle campus, as well as director for the Center for Anti-Racism and Community Health. It is our pleasure to share our approach to public health accountability in action.
Our article in the Public Health Reports supplement describes how this advisory group improved the Seattle and King County Health Department's community mitigation policymaking during the COVID-19 pandemic. The advisory group made 75 recommendations over 2 years, and the health department adopted 88% of these. Examples of recommendations include a fully adopted recommendation in May 2020 to report COVID data by race and ethnicity. A partially adopted recommendation to translate COVID health information into additional languages. 11 languages were recommended by the advisory group, and 5 were actually produced. At Public Health Seattle, King County, we found that a visible mechanism of organizational accountability was needed to help operationalize our department's declaration in June 2020 that racism is a public health crisis. In our first year of the advisory group, before we started using a tool, staff rarely reported back how recommendations were being acted on, whether fully or partially. And advisory group members told us they felt demoralized, like they weren't being listened to. PARCAG has a 6-person community-led steering committee with 5 community leaders and 1 public health representative. This steering committee asked for an accountability process to regularly share back what the group had recommended and what happened to these recommendations. So as staff, we began using this simple flowchart in March 2021 as a way of letting the group know about their growing influence within the department. The steering committee also changed the PARCAG meeting format from being mainly report outs to starting with a check-in question like, what's on your heart today? So we hear everyone's voice at the beginning of every meeting. It's become 20 to 30 minutes of relationship building time well spent. As you can see, the tool starts with the advisory group's recommendation in the left light blue box, then shows in purple what staff and steering committee members do in response to the recommendation. In orange, we highlight who has the authority to make this decision, often the local health officer, what was decided, and whether additional follow-up was needed. The tool has been a good start to making health department decision-making more transparent to community, but over time, we've wanted to improve it and use it more consistently. Public Health has contracted with Dr. Barrington and the Arch Center to take stock of how the tool is used and how to improve it.
In addition to PARCAG members, staff also noted that the use of the accountability tool has not been visible or consistently applied. Therefore, our aim was to describe perceptions of the tool, to not only reveal what actually goes on within these colorful boxes, but identify process improvements to streamline, build out, and improve the experience of using the tool. A core component of our evaluation of the accountability tool was the application of an anti-racism lens and data analysis, and when generating recommendations for tool refinement. We interviewed a total of 13 people, including both staff and PARCAG members, and used the Public Health Critical Race Praxis, or PHCRP, to organize our thematic analyses of tool perceptions. Interview data were easily sorted within PHCRP principles and foci. 4 of those most highly represented are listed on the slide, including voice, intersectionality, structural determinism, and action. For voice, one participant noted, quote, "We've made the intent to have at least 60% of the representatives of the steering committee and also PARCAG overall be, Black and Indigenous." While it's very exciting to see that staff and PARCAG members are committed to embodying anti-racism principles in their practice, it is also apparent that a specification of strategies, actions, and behaviors is needed which can also point to additional points of refinement for the accountability tool. We have framed out some guiding questions to help us with that specification and refinement. Following through on voice, while ensuring Black and Indigenous representation of PARCAG members is one strategy to center voices from those communities, one could also ask, what elements of PARCAG process, norms, or practices can align with Black feminist or Indigenous knowledges? Taking an intersectional approach, one could also identify and build in elements or supports from other knowledges and experiences of oppressed peoples. PARCAG was birthed as a result of the declaration of racism is a public health crisis, which itself stood on the legs of the pandemic, structural racism, and the murder of George Floyd, as well as countless other killings of Black and Brown people. We offer that this can serve as a structure, or in this case, a stool, to use when pulling up to decision-making tables, as well as when sitting, dreaming, organizing, and resting in community spaces. Yet we also offer that this structure is hard and can be layered with a cushion of health equity practice. The accountability tool seeks to provide strategies for organizations to do just that. Strategies that are co-created with communities directly impacted by colonialism, as well as structural racism and discrimination. Thus, PARCAG has been reborn as the Health Equity and Anti-Racism Community Advisory Group, or HERECAG. Thank you, and we'll now pass the mic to Britt Lang.
All right. Hi, everyone. So nice to be here today. My name is Britt Lang. My pronouns are they, them. I'm a senior research specialist at FAB, or the Public Health Accreditation Board, and I'm here today to talk to you about my paper, Equity Work Among Accredited Health Departments in the United States, 2015 through 2021. And I have no disclosures. So the objective of our paper was to examine the relationship between public health accreditation and work related to health equity by analyzing accredited health departments' responses to a prompt in FAB's annual report. And so for folks who are unfamiliar with FAB and public health accreditation, this can require a little bit of background. So FAB is the accrediting body for local, state, and tribal public health departments in the United States. Currently 447 health departments and 5 vital records and health statistics units are accredited. And so that comes out to about 90% of the US population is in some way covered by an accredited health department. And so accreditation provides a framework for health departments to identify performance improvement opportunities, demonstrate credibility, develop leadership, and improve relationships with the community. Serves as both an accountability and transparency mechanism and is a step on a journey to transform public health practice. And so initial accreditation lasts for 5 years. And then health departments complete annual reports every year after becoming accredited. And so the purpose of those annual reports is to ensure that accredited health departments are remaining in conformity with the standards and measures under which they were accredited, and also provides opportunities for additional engagement with FAB in between those accreditation cycles. So what we were looking at was that we analyzed the self-reported responses that were provided to the annual report. And this is for responses that came through from January 2015 through December 2021. And then we identified themes looking at those responses using a priori and inductive coding. And so the questions that we looked at, the first was, has the health department conducted work in any of the following areas? And so that then provided a list of around 18 topics, which included things like behavioral health, climate change, health equity. And so folks could select as many as were relevant. And then a following question, which was that if your health department was engaged in work in one of those emerging areas, so that's one of those 18 topic areas, to tell the story of the health department's work in that particular area. Oh, I'm trying to go to the next screen. There we go. So what we found was that there were 316 health departments that completed an annual report in that time period, 2015 through 2021. 283 health departments, so that's almost 90% of health departments self-reported that they were engaging in some work related to health equity. And then among those 283, 50 health departments decided to provide their narrative explanation to be around their health equity work. And of course, for that narrative, they do get to choose among any of those topics that they selected that they engaged in. So 50 folks decided to talk about health equity. And so here are our results. So we found that almost half of those 50 health departments were engaging in community partnership work, which we defined as an ongoing relationship between the health department and organizations among their constituents that promote health equity. 17, or about a third of the health departments, were providing access to COVID-19 vaccination, which we described as programs specifically for access to COVID vaccinations for racially and socioeconomically marginalized communities. 16 health departments reported that they had an internal role related to health equity, which we defined as any role, team, or division within the health department that had a stated purpose to promote health equity. Also, 16 health departments had programs related to health equity. And then 11 health departments reported that they were conducting internal training related to health equity. And so those were our findings. And so when it comes to our conclusions, we found that most accredited health departments are completing work related to health equity. Of course, a limitation of this study is that we don't know exactly what all of that work is. Because only 50 of those health departments decided to provide that narrative regarding that work, we don't have information on the vast majority of those health departments that were completing work related to health equity. And so therefore, we also need some further research to examine characteristics that influence health departments' likelihood of conducting health equity work. And so models and resources on how health departments, particularly small to health departments, can begin equity work would be valuable. Thank you.
Hi, I'm Chris Rhodes. Thank you. On behalf of my team of American Indian and Alaska Native authors from across Indian country, we are honored to be included in this work. Today, I plan to introduce you to the highlights of our paper, which was a commentary in public health reports. I hope to increase your understanding on public health data collection and analysis to American Indian and Alaska Native communities. Of course, data equity of American Indian and Alaska Native people is a crucial piece of health equity. And American Indian and Alaska Native health equity begins with critical shifts in the centering of tribal knowledge, community values, and data sovereignty as key components of transforming public health systems. As the title of our paper suggests, concepts of sovereignty are key to improving American Indian and Alaska Native public health data. There are 574 tribes in the United States, and each tribal nation has the inherent authority is to govern and protect the health, safety, and welfare of its citizens. Each tribe sets up a government structure, defines citizenship, makes and enforces laws, and manages associated data, and has multiple interfaces with surrounding data systems. And with tribal data sovereignty, that is the right to ownership and governance of the collection and use of tribal data. It is a powerful equity foundation, and it can provide the accuracy and relevance of data. It represents tribal circumstances, customs, and worldviews, tribal sovereignty, along with critical shifts in the recognition and inclusion of tribal knowledge systems, data sovereignty, and community values is absolutely key to transforming public health data systems across all governments. Public health data are necessary to identify, respond to, and mitigate public health threats, but the data are often held by non-Indigenous governments and institutions and are not always representative of or available to our American Indian and Alaska Native public health systems. Federal, state, and local governments have not consistently upheld or supported tribes' rights to access data, and tribes are not always fully integrated into their surveillance systems and other public health data systems or networks. Tribal data practices exist. American Indian and Alaska Native people continue to uphold tradition of data collection to ensure the health and well-being of the community since time immemorial. For generations, data keepers have used oral tradition, objects, prayer, and artistic expression to disseminate knowledge. Data remain embedded in storytelling and cultural practice principles and are transmitted orally and or through winter counts, songs, ceremonies, calendars, totem poles, buffalo hides, and other ways. Tribal ways of knowing are often misrepresented, overlooked, or extracted and misappropriated because of colonial and misogynistic ideologies, systemic racism, and misappropriation that permeate institutional public health data and research. We want to recognize that all tribes have their own data practice. Few are represented in the scientific literature, but we do have two examples to highlight here where tribal nations have worked to develop tribal models of health and well-being and pilot these models and publish the findings. Again, finding these models and with principles and measures that tie back to what truly is public health practice and well-being. Our panel of co-authors and the panel that was convened to do this work came up with a long list of recommendations for improving data. Some of these recommendations are aimed at governmental public health agencies. Some are within tribal public health systems, and some are with our partners in academia. Tribes advance their sovereignty when tribal public health systems reflect tribal teachings and values. Therefore, we need to move beyond a deficit-based view to a strength-based public health approach and engage diverse community voices to identify public health data that center tribal values and are relevant to community well-being. These recommendations again, are for all public health professionals striving to improve American Indian Alaska Native public health data equity across governmental and public health authorities. And in closing, American Indian and Alaska Native health equity begins with critical shifts in the centering of tribal knowledge, community values, and data sovereignty as key components of transforming public health systems. Tribal public health leaders are working to strengthen public health infrastructure and capacity and establish roles to advance American Indian Alaska Native data and health equity to measure the well-being of American Indian Alaska Native people in our modern context. So as tribal public health systems reclaim tribal data sovereignty and tribal data governance, they are developing culturally centered indicators to be integrated with all public health data systems. All public health leaders can positively contribute to American Indian and Alaska Native public health data and overall well-being by approaching the work with an understanding of sovereignty. Thank you.
Hello, everyone. Welcome to this session. We will be sharing highlights of our paper in the Public Health Reports Journal Evaluation of the COVID-19 Vaccination Campaign Andele que Espera in Latinx Communities. My name is Syra Nawaz, and I'm a health services researcher and evaluator at PATH, which is an international health NGO that works in 70 countries to accelerate health equity. And I'll go ahead and pass it to my colleague, Rosa, to introduce herself and provide some introduction to the actual study.
Hi, everyone. My name is Rosa Vasquez, and I'm a community engagement specialist here at the Ultimate Institute for Health Equity. And I'll be providing a bit of the context for the campaign. Ultimate served as one of the lead implementers for the campaign, but this was a statewide campaign across the state of California. So I'll be talking a bit about that as well. Starting off with the aims for our presentation today, we really want to discuss the findings of this 12-month grassroots outreach campaign that meant to address vaccine disparities. But beyond that, we want to really think through how we can leverage the findings that come out of initiatives from the COVID-19 campaign to really inform how we address inequities that may arise moving forward. We also want to challenge some of the narratives around what vaccine hesitant or hard to reach communities look like. We firmly believe that there aren't hard to reach communities, but rather that we maybe don't know how to reach them. And instead start to shift towards a structural lens and how we can analyze the root causes of the inequities or the ways in which our systems are not able to reach those communities. We also want to explore the structural factors that drove the vaccine disparities that we saw and the facilitators that emerged from our campaign for what actually supported vaccine confidence and vaccine uptake. And then finally, we really want to think through how we can elevate the significance of community health workers in bridging systemic gaps and ultimately in advancing health equity. A bit of context for what informed this campaign and how is it that we come to this intervention. So one thing is that we knew from the beginning of the COVID-19 pandemic that the pre-existing health inequities in communities that had been marginalized and excluded from public health systems were deeply rooted in other systemic inequities that were resulting in social determinants of health disparities and like the context that communities were existing in. That laid the foundation for COVID-19 to really devastate communities that were already just trying to survive, that were already having to rely on social networks to ensure that they were supported and had very little infrastructure for public health reach or public health service delivery. So that's where we began to see higher exposure risks, hospitalization rates at disproportionate levels, mortality rates, and other kind of economic effects. A lot of the analysis of these communities at the time, beginning of maybe 2021 into 2022, was an analysis that deemed communities hard to reach, or even headlines that deemed Latinx communities across the state of California vaccine hesitant. We really wanted to think about how we flipped the script and thought instead about how there was a lack of information delivery systems in these communities, how we really didn't know how to reach them, how to approach communication in a culturally humble and community relevant way. And that informed the campaign. So the Ándale que Esperas campaign was a 12-month grassroots outreach campaign that ran from June 1st, 2021 to May 31st, 2022. And its aim was to enhance communication and COVID-19 vaccine access in communities that were made vulnerable, not only by the pandemic, but because of structural racism and historic disinvestment. This campaign was implemented, as you can see in this map. This is all of the different implementation sites, but it was implemented at 5 different regions throughout the state of California. 4 of the implementation sites, or the lead sites, were clinics, federally qualified health centers, and then one of them was actually Latino Health Access in Orange County, which is a community-based organization. But each site had 4 main areas of work. One was that they hired and trained and mobilized community health workers, and really thinking about how community health workers with their lived expertise were positioned perfectly to bridge the gap that existed between systems and communities. And also that lived expertise could really carry through as we were navigating very uncharted waters. We thought about multimodal communication campaigns to ensure we were reaching folks in their homes, through social media, through digital campaigns of other sorts like text messaging and phone banking campaigns. Also thinking through how we could mitigate barriers that were structurally preventing people from being able to uptake the vaccine or actually exposing them to worse COVID-19 outcomes, and directly thinking through how we could connect folks to vaccines. And that was each site. And then each site also received support from the statewide Ándale que Esperas campaign and from Dr. Nawas, who was the statewide evaluator.
Thanks, Rosa. So this project was funded by the Health Resources and Services Administration, and for that reason, it required some mandated data collection, particularly around the number of vaccinations provided and the demographics of those who were reached. We decided to strengthen the data collection to capture more contextual information that was relevant to each of the 5 diverse communities. In terms of evaluation objectives, we explored the predictors of the vaccination rates and essentially the number of vaccination and the barriers to vaccination. And drawing on methods from monitoring, evaluation, and implementation sciences, we collected information about the location and outreach strategy that was used, the support services that were provided, the number of vaccines that were provided, and reasons for delay in vaccination, as well as other contextual information. Next slide, please. So in terms of results, a total of 146 community health workers were hired across the 5 communities. You can see the number of outreach engagements that were conducted, the number of supportive services that were being provided, which included transportation, translation services, specific one-on-one education, support with vaccine registration, or just to name a few. And then you'll also see the number of vaccinations that were realized after 12 months of follow-up. We also found that the provision of supportive services, unsurprisingly, actually significantly contributed to the number of vaccinations. And we also found that many of the folks amongst those who were actually vaccinated before vaccination reported concerns, including vaccine confidence and then challenges with access. Next slide. So here are our key findings that we've highlighted in the article. We highlight that the ability to provide supportive services really was associated with an increase in the number of vaccination, especially amongst vulnerable populations. And what we also tried to track is, well, how does this compare to the rates of vaccination within the state? What we realized was that there was convergence of the trends in the number of vaccinations within the state, as well as what we were seeing within our 5 communities, suggesting that the community health worker model that was being implemented was actually helping to catch up with vaccinations in vulnerable populations. And as Rosa was mentioning, this campaign was really grounded in being informed and driven by the lived experience. And what we found was that the campaign, in fact, highlighted the importance of integrating some of these principles, not only in program design and implementation, but for improvements and adjustments that happened along the way. Thank you so much for your time, and I will pass it back to the moderators.
All right. I want to express thanks to our esteemed panelists. We deeply appreciate the brief but poignant insights that you've each provided into your work. So ladies and gentlemen in the audience, at this particular point, we've reached in a very exciting part of the webinar where what we want to do is initiate discussion. The panelists actually have been answering questions in Zoom throughout the webinar. And I also want to express thanks to those who have been engaging with our panelists throughout. There are a number of questions that have been answered. I'd like to begin the discussion section with any remaining questions that you, the audience, have posed. And I want to also welcome any other additional questions that, if not already posed, are top of mind for any of you that still wish to have some conversation, to have some engagement with our authors today. So as I look at the QA section, one question that I see is as follows. Would it be possible to gain access to the Andele que Esperanza information? And I think that's a fairly straightforward question. Would it be possible for our last presenters to address that question live?
Yeah, we are more than happy to share information about the campaign. We can definitely share the link to the paper that we wrote that we presented on today, but then we also actually ended up writing another paper that analyzed just the community health worker model. So y'all can reach out to me. I'll put my email also in the response to this. And we can also share with the moderators any information we can send out via email to participants.
All righty. Thank you so much, Rosa and Cyrus. We deeply appreciate, again, you being willing to speak to, the incredible, important work that you have presented. Another question just popped up immediately after that one. Would you be willing to address that?
Yeah, so the question is, the America Esperas campaign was truly inspiring. How much did it cost? So we actually received an $11 million grant from HRSA for this campaign, and that money was distributed to the 5 sites and then also leveraged to create the infrastructure for the statewide campaign. It was the first time that Altamed was leading a statewide campaign that was doing service delivery, and it was building off of a civic engagement campaign. So $11 million, we believe, fairly well spent, and it did build infrastructure that we are now sustaining through different partnerships with those clinics.
Okay, thank you, ma'am. And there's one last question. You've got a hot potato at this point. The person says, I came a bit late, but I always have struggled to collect demographic information for outreach events. Any tips? And I do think this might also be a question that could extend to others that have similar expertise if they wish to respond.
I can take it first stab and then happy to pass it over to anyone else. But tips that I think have worked really well for our work are definitely trying to first find out what language the community speaks in terms of demographics. I think trying to impose demographic language often makes it really difficult because you then have to sometimes even explain or educate around what the term means. But if you go into the community and kind of start to ask folks like, how do you identify? What does your community look like? Who lives here? You begin to get a good sense for how that community talks about its own demographics. And then it becomes an easier conversation where you're like, okay, maybe I'm asking you about race and I'm not going to list out the 14 different races that my survey is saying, but instead I'm going to ask you in an open-ended way. And I'm going to try to code what you're telling me. And so it doesn't get easier, but I think that learning the language that the community is speaking does give researchers and evaluators and implementers of any kind the tools they need to ensure that they are meeting the community where they are at, not just physically, but also in language and undoing any barriers that we might accidentally be creating.
Thank you again, Rosa. We appreciate your perspective. Delight, yes, ma'am.
Thank you, Rosa. Thank you, Jeff. I have an interesting story to share about collecting demographic information in outreach events. This is from like 30 years ago. We came up with this methodology. So it can be subjective or objective, right? You can be asking the public to share their information, but sometimes that should be done in a private way. And then you can also ask your outreach workers to make assumptions about who they're engaging with. But you don't want it to be over, oh, let me get my tally sheet out and write down who you are. And so at native events, you might use beads. So a bead, a yellow bead is somebody who is 50 and older. The pink bead is whatever age group. Green, adolescents or children, or whatever you're interested in learning about. And the outreach worker just picks up the bead casually and puts it into a shell, or picks it up casually and puts it into a basket on their side of the table. You can also ask the public to share, who they are, and they're picking up beads and throwing them into it like the big jar. And people love it. And it allows them to share a little bit about who they are, you to collect some information and be respectful about, those demographic variables that are sometimes sensitive.
Thank you, Delight. We appreciate those words of wisdom. Wendy, I see your hand is up next, ma'am, please.
Thank you. I was also just going to offer that, acknowledging that we are working together to improve health equity is really the underpinning and the grounding for the reason why the data is being collected. And if people would be willing to share that information, that information will be anonymized, but it will be kind of taken and aggregated in order to use to advocate for programming and resources and understanding, what the health needs are of the community. But really, I think once people understand that this is for advocating for communities, and that's the reason why the data is being collected, I think that can be helpful as well.
Okay. Great answer. Thank you, Wendy. The next question is as follows, and Britt, this may be one that I want to aim towards you, but again, I think it might also be something that's relevant to others, including you, Christy, as well as Ashley. But one of our attendees posed the following: any words of wisdom for how to best engage state level leadership in diving deeper, or even in starting on incorporating health equity into public health work, especially when it's not already ingrained?
Yeah, that's a great question. And I think something that a lot of folks are encountering in this political climate. So I'd say, I think first off, one of the things I'd recommend is to consider some alternate language, or kind of euphemistic language. Things I've seen health departments have success with are using things like fairness or equal opportunity, access to care, abilities and inabilities. Sometimes just using that alternate language keeps people's hackles down and might make them more amenable to collect data. That's really important. So that would probably be my biggest recommendation, because I think generally when you start to describe health equity principles to people without using the word health equity, most folks, regardless of affiliation, are going to be like, yes, this is important and valuable. It's just those words that really sometimes get people concerned. So I think if you can talk around it, and it seems silly that it's that simple, but we really have found that health departments do have not always, but pretty good luck if they're able to just kind of talk around those hot button terms.
No, and thank you for that perspective. I think it's really critical to be able to, at bottom, speak to people from the heart, when sometimes speaking from the head doesn't necessarily take you, to the place where I think we're aiming to be. Are there any others on the panel that wish to comment where that particular question is concerned? Okay. If not, I see that Rosa is in the process of answering the next question. I'll give her a little bit of time to do that, and I'll come back to that question, if time permits. I'm going to jump to the last question that is in the box at this point. And this question is for Dr. Rhodes. A recommendation you provided was invest in linkage projects that cross-reference data to prevent racial and ethnic misclassification. Will you project what potential linkage projects would look like?
Yes, I'd be happy to. So I am, just clarification, not Dr. Rhodes. I have a master's in public health. I am happy to share linkage projects have been an important piece of data in Indian country where people are born American Indian or Alaska Native and sometimes die not as another race. And that's just how data is collected. And so the linkage projects are really between tribal and IHS systems and connecting those with and comparing and contrasting with state level projects. My colleague Delight, who's on the call, I'm sure will be able to quickly put the link in for there's a really great example that happened in Michigan around breast cancer. Again, many examples where our population isn't always properly categorized. Thanks,
Thank you,
Delight.
Chris. You know, we appreciate your response to Craig, my colleague's question. Craig's an inquisitive guy. It's always good to have him present because he's going to ask good questions. I have one question that I do want to pose to Christy or to Ashley. Given that your particular work really focused on improving surveillance, data collection specifically for 3 populations, people with disabilities, persons with substance use disorders, and individuals who are experiencing homelessness, is there any guidance that you could give us with respect to how we might think about how to anticipate changes, you know, so that we could, as a public health community, better support the data and the intervention needs of those 3 communities when it specifically comes to things such as future public health response activities?
Hey, yeah, absolutely. Well, first, I just wanted to say I'm a little slow on the raise the hand button. But in terms of interfacing with our state partners, I think a great thing is to always have a forum where people at different jurisdictional levels can talk to each other about what public health benefits they've been able to see in their area based on work they've done in this. And therefore, like, you know, they might have common challenges they're identifying and also can share best practices, because a lot of times, you know, that voice from someone with similar experiences can really speak a lot. And then also focusing on what is our core central purpose and how does this serve this? Like what brings us all together? And that's in really trying to serve people, improve health outcomes for everyone. And also we're all really working on, you know, how to best use what we know are limited resources to support public health. And so, you know, any information that we can use to do that, I think serves a common goal. So focusing on that can be really helpful. Secondly, about how we can better serve disproportionately affected communities, such as the populations of focus in our work. I'll speak to some things on the data side, then I'll hand it over to Ashley for some information more on workforce and community. But in terms of the data side, I'll give a couple examples. In 2021, subject matter experts at CDC put forward to the US Core Data Standards for Interoperability, or USCDI, process a data standard for persons with disability. That was adopted in 2022. Now, this process goes a little slowly, so it'll be required by any health information technology system, such as an electronic health record, in January 1st, 2026. The next challenge is going to be making sure that data standard in that question is actually used and incorporated. So if it's in the health IT system, we need to work on consistent implementation. We're also have been working hard on coming up with a tool to be able to standardize the collection of housing data to address that thing I was saying about how someone in the same situation could be classified differently based on where they are. And we recently are very excited to say that we completed a validation study of that tool, and that will be moving quickly toward publication. And over to Ashley for some workforce items.
Thanks, Christy. Just a couple things that I want to highlight. The first is that we have a free online training for public health professionals on homelessness. So what might someone at a public health department need to know about homelessness? That way they're equipped and ready to respond to support the population of people who are unhoused. The other thing I want to mention, something that we found to have success in a number of states and counties is having a designated point person for things like homelessness or housing instability or for disability embedded within a health department. That way there's one source, one person to go to that kind of cuts across all of the disease outcome areas. Homelessness and housing bubbles up in every health outcome, but having one person that kind of thinks across health outcomes is one way to bolster workforce and capacity. And then the last thing I'll say is echoing what Christy was mentioned in terms of forums where folks can come together and learn from one another. We have been working to convene state and local health departments around homelessness and incarceration, really to help build that capacity within health departments and allow them to learn from one another to better support these communities, both in blue skies times and in response times.
Okay, thank you both for the detailed and informative answers that you provided. I believe the last question that I see in the chat is posed towards the two of you. And one of the things that it speaks to is the idea of connecting with hospital systems and community care clinics with the purpose of sharing stratified data sets, which is, obviously a good question. Is that something you would be willing to speak to quickly? Either Ashley or Christy.
Sure. I'm sorry. I'm having a little bit of trouble locating the question in the chat, so I wasn't sure. I want to make sure that I am actually answering the question. Oh, I found it. Okay. I think that one of the most important things that we can do is to engage with communities and also engage with people who provide data within data systems to show them, what are the results coming back and what can be done with the data, what conclusions they can draw from their own data, because one of the biggest barriers to robust and quality data collection is people feeling like it's sort of going into a black hole, never to be heard from again, right? And so we're very invested in sharing back with partners. I'd have to look back at the specific partners that you're talking with, because everyone kind of is under a different structure in terms of how to best communicate. So I would be happy to follow up with that individual regarding specific structures. And over to Ashley.
Yeah, I just want to highlight specifically on the homelessness side, we've seen a lot of really great data sharing opportunities between homeless management information systems and health information exchanges. In a number of communities, I'm thinking of Chicago specifically, has been able to identify who's missing in each of those data sets in terms of the context of homelessness. So there are a lot of opportunities there, and I know we're right on time, but I did just want to plug that there are a lot of data linkage and match.
Okay, thank you so much to you both for your answer. And Wendy, I apologize. I didn't see your hand a little bit earlier. Please forgive my oversight. We are very appreciative of the interest and the questions. They just blew up there at the end, which is always a wonderful thing. It shows excitement. But ladies and gentlemen, we've actually reached the point where I have to pass the podium back to Dr. Dean, back to Hazel at this particular point. So I want to express thanks to each and every one of the panelists today for being present, for sharing your insights, and for conveying your experience. And I'll now pass the podium back to Dr. Dean for our closing. Hazel?
Thank you for joining us today. You may access the full special issue at https://journals.sagepub.com on the homepage. A special thank you to the speakers and their staff for their time and contributions addressing the major health challenges facing the United States today. I also want to thank the Association of Schools and Programs of Public Health Reports, and the Office of the U.S. Surgeon General for their continuous support. As a reminder, this webinar will be archived on the ASPPH YouTube channel for future viewing. This is the end of the ASPPH Presents Public Health Reports, Meet the Author webinar. Thank you and have a good day.